The various things that we look at are thoracic aortic anomalies, including aortic atresia or interruption of the aorta. Presence and size of pulmonary arteries are the most important things, or the largest segment of our population, and that will decide the kind of surgery these infants will go through. Either they'll just get a palliative BT shunt, or they will go for a complete repair. So our estimation of the pulmonary arteries, we use two indices. One is the Magoon's index, where we image the RPA, LPA with the descending thoracic aorta, and also the Nakata index. We use both depending on the situation to accurately give us the sizing by body surface area, and this also helps with the surgical plan. So anatomy of very complex ventricle anomalies, especially patients with remote VSDs, DORV and the like, sometimes which cannot be totally delineated by echo alone. Pulmonary and systemic venous anomalies, it's a very good test for follow-up after surgery, especially after the switch surgeries. Situs abnormalities can be tricky on echo, and some of these difficult cases we do image. We have infants with LPA or RPA stenosis. 5 years or 3 or 4 years ago, we used to do a nuclear imaging to look at perfusion of the right or left lung, seeing whether the RPA or the LPA is sufficient to give blood flow. But now we've stopped doing nuclear images because of the radiation, and we are just doing VEC imaging of the particular artery, RPA or LPA, and we are seeing whether the flow is adequate or not. So this really helps us to tell the surgeon whether to increase the baffle onto that particular pulmonary artery or to just keep it onto the main pulmonary artery. Quantification of shunts we've started doing, and this is a very good non-invasive way. I'll just show you an example. Most of these children had to go for CATs, which is a 30 to 40 minute procedure. Patient is almost hypothermic in the cath lab, and we can do that safely in the MR, much shorter time with just a venous injection. Collateral circulation, again, I just talked to you about how we are now doing VEC images in the proximal and descending part of the aorta after the stenosis. Measurement of pressure gradients across both surgical conduits and across the coarctation. And also what MR is really good for is quantification of ventricular mass and volumes, and we're especially doing this in patients who have had atrial switch repairs where the RV continues to be the systemic ventricle, and we are able to actually see the RV failure at a very much early stage. The other large kind of study that we are also doing is most of the patients with tetralogy of Fallot 10 years ago or 5 years ago who were operated never got a pulmonary valve annulus, so they have significant pulmonary regurgitation. So we image the RV and the extent of regurgitation and quantify it. So just to tell us about what is really good as an imaging tool, especially for this kind of infants, it also deals with the availability of the equipment and the expertise at the local institution. Thankfully, these videos are playing, and this is an example of a coarctation of aorta, and you can see the right-hand picture. This is the MR contrast image showing a severe discrete coarctation. What is also important is we note the collateral, significant collaterals which are there, and also the shelf extending from the distal left subclavian artery right down to the quark, because once you have a significant shelf, these infants are actually well suited for an intervention. They're well suited for a stenting, endovascular stenting, rather than surgery. 5 years ago we used to send them for surgery, but we're doing a lot of stenting now, and the infra LSA shelf is very important so that we can adequately place the proximal portion of the stent. So that information is very important. And this is also to show you the VEC imaging which we were talking about. And we are able to calculate the gradient. So many times in echo, because of the angulation, it's not possible to accurately have a Doppler lined exactly right. So severity of coarctation in a child who is being systematically evaluated, especially a moderate degree, MR gives a good picture. And what we were talking about, which has recently been validated, is we put a VEC image here, see the flow just below the coarc segment, and we put another one just here. And we found that in patients with severe coarcs by echo, we find that the one here, distally, the flow is much more, showing that all these collaterals which you're seeing here.
Sorry to interrupt.
Okay.
The video is not showing on this. Yeah, it's great.
Is it playing? Okay, it's playing here.
Just check if your videos are working.
Yeah, I'll just show you some of the videos once I finish. This is a 3D reconstruction. I'll just play the original movies. Is this working? Oh, this is also gone. It seems to be working in this laptop. So this is again a cine sequence of a patient with the PDA. You can see the flow disturbance here. And we're also able to, I'm really sorry, we're not able to see that. We're able to actually quantify the gradient across the PDA, the flow from the aorta to the pulmonary artery, and that gives us the important significance. And this also helps us in planning for a device. I will just play the videos after this. This is a 7-year-old child with, oh my, okay, it seems to be playing here for some reason. Okay, let me just, can you see the still picture? Okay, I'll just, I'm not going to play it because it's disappearing. This is a child with an abnormal pulsation, chest pulsation and murmur, found to have some kind of a mass on echo. And this is nothing but a sinus of valsalva aneurysm, not yet ruptured. And this is a good case where initially surgery was being offered to these children, but now we're able to actually put in a device and close these sinus of valsalva aneurysms. Fortunately, it's not playing. Okay. So,
Can you do a function F5 or F7 or whatever? Let it not play on your laptop.
okay.
Maybe there's a memory issue. It might still play on.
Function F5.
Maybe it's any of the.
I can play the videos from the thing directly, although I'll once I just finish, I'll just play these videos because these are important. So this is an example of a 12-year-old child, abnormal ECG, abnormal echo, showing an RARV dilatation, and this is a very classical case of an Epstein's anomaly, and you can really see here that we're able to quantify the TR jet. Not able to do that. We're able to confirm the diagnosis on echo, and we are also able to show the. Okay. I'll just play them directly. It's playing now. I think that's the one. Okay. We are actually able to see the septal leaflets which are far below into the RV, and also the flow disturbance. And this is an important calculation by which we send patients for surgery. This is an 18-year-old boy with chest pain on exertion. He does some track and field work, and he had an abnormal ECG. His treadmill was abnormal, and we did find an anomalous coronary, right coronary, coming from the left coronary sinus, passing between the MP and aorta. This is a 13-year-old child, again abnormal ECG and echo. Echo was not very clear whether there was a pulmonary stenosis or whether there was some kind of a hypertrophied RV. And here you can see the MR picture. You can clearly see that the RV is almost divided into two chambers. The proximal chamber and the distal chamber or the outflow chamber with very thick muscle bundles, and this is a case of a double chambered right ventricle, this with a very, very small tiny VSD. So this child eventually went for surgical repair. Yeah. This is again infant with cyanosis and heart failure, and you can see that this patient had a pulmonary atresia, and we could clearly show the MAPCAs here, which are arising from the descending thoracic aorta. These were sort of plugged later on with a vascular plug, and the patient went on to have surgery. And this is again a classical indication of a 3-year-old child with cyanosis and spells. And here we have, with MR contrast, we have accurately shown the RPA, you can see, which is significantly stenosed. And this patient went for an intracardiac repair with a patch extending onto the RPA. And this is one of the projects that we are involved, where we are looking at children who have been operated for tetralogy, and they come with heart failure, and you can see the dilatation of the RV, and you can see here the lack of the pulmonary valve post-surgery, and that is contributing to the RV dilatation and failure, and we're able to quantitate on MRI the antegrade and retrograde volume, and thereby measure the regurgitation. And this is again a group of children that we are doing post-atrial switch, and you can see here the pulmonary veins enter the RA. They have been baffled into the LA, they baffle into the RA, and the RV goes into the RV, and the RV extends into the aorta. This is an atrial switch, so we are very keen on seeing the performance of these RVs many years down the line. And we are also able to do a stress for them outside and then put them onto the scanner again and look at the RV performance. And this is an arterial switch. This is what I was telling you about, the extracardiac baffle that we use for a Fontan surgery. And we like to see the flow here because thrombosis is quite common. So we use the VEC imaging and the cine imaging to characterize this particular baffle. This is again a 15-year-old boy who came in with a murmur, and we found that he had a significant shunt. You can see the QP by QS was significant. We were not able to find any shunt on the echo. So when we did the MR imaging by cine and contrast, we found that there was a small partial anomalous venous connection into the RA and the RV. So this was a case of a PA-PVC. But we also get the additional information of the RV ejection fraction. You can show that there is mild RV dysfunction compared to the LV and the stroke volume, which helps us for the repair. And these are the various cross-sectional cuts of an atrial septal defect. We are currently evaluating the role of MR versus TE, and this has been recently published as to the non-inferiority of MRI compared to transesophageal echo, and MR is non-invasive compared to TE being semi-invasive. And this is again a child with a murmur, an abnormal stress test, and you can see the septum, and you can see we use the tagging preparations to show that the septum is not functional. And also there is scarring in the septum showing the child is at high risk for sudden cardiac death. So I'm going to stop here and just conclude by saying MR is very good for cardiac anatomy, measuring blood flow and quantify ventricular function. Ventricular pressures, vascular pressures, PVR and SVR it cannot do, so we need to do a cath for some of these children. However, there are XMR laboratories now in fact in the NIH lab they have a cross lab with an MR scanner and a cath lab, and they're also using MR compatible catheters, both passive tracking and active tracking, to assess the flows and thereby get PVR and SVR. Thank you.